listening to the Pharmacy Podcast Network.
This is the PGx for Pharmacists podcast. We believe pharmacists are the best positioned providers to lead in PGx. Pharmacogenomics is the study of how genes affect a person's response to drugs. This relatively new field combines pharmacology and genomics to develop effective, safe medications and doses that will be tailored to a person's genetic makeup. This podcast is dedicated to pharmacists with an interest in learning more about the data analytics, industry trends, and evidence-based usage of pharmacogenomics. Welcome to PGx for Pharmacists, part of the Pharmacy Podcast Network.
Hi, everyone. My name is Benas Sarami, your host to PGx for Pharmacists podcast on the largest pharmacy podcast in the nation and one of the top 20 podcasts in genomics globally. If you're new to the podcast, I don't know why you would be, but I'm the Pharmacogenomics Medical Science Liaison and a mentor to pharmacists. Connect with us on LinkedIn and let's get the conversation going. We want to hear from you and how you're impacting patients, payers, clinicians, and what you've learned through your journey that you would want to share with us. Being a PGx advocate requires going beyond a certificate and reading an actionable genetics report. So we want to hear from you. Let's connect.
And I'm Becky Winslow, your co-host for the PGx for Pharmacists podcast. Most of you know by now probably that I'm a PharmD with 15 years of clinical pharmacy and pharmacy operations experience and almost 10 years of medical affairs and business development experience with Pharmacogenomics Company. If you've been listening to Benas and I, you know my PGx knowledge and experiences complement Benaz's, and that's how we're able to bring our listeners such a comprehensive view of pharmacogenomics. A great way to describe the content that we bring you is that we educate our listeners beyond the PGx certificate program. With this being said, let's get today's episode rolling. We have a very famous, if you want to call it famous, well-recognized.
I like famous.
Yes, very well-respected member of the pharmacogenomics community with us today on the episode, and that's Dr. Dave Kisor, who you guys probably well know is a professor and director of pharmacogenomics at Manchester University. Just to give you a little bit of background about Dave, he graduated from the Ohio State University College of Pharmacy in 1986, and he completed a 2-year fellowship in therapeutic drug monitoring or pharmacokinetics at OSU. Before he joined Manchester, Dave was a professor of pharmaceutical sciences at Ohio Northern University. And this followed his work as a research scientist at Burroughs Wellcome Company or GlaxoWellcome. Very impressive stat here. Dave has over 80 peer-reviewed publications.
Becky, that's 80. That's a lot. That is very impressive. Okay, sorry. I had to say that.
Yes, that's a lot. This includes him being the lead author on 2 pharmacogenomics textbooks. He's the past chair of the American Association of Colleges of Pharmacy, Pharmacogenomics Special Interest Group. Dave was also named a fellow of the American College of Clinical Pharmacology in 2017. And in 2021, along with Dr. Tom Smith, he received an AACP Innovations and PGx Teaching Award. His current research is related to pharmacogenomics and opioid use disorder. Dave currently serves as co-chair of the Pharmacogenomics Global Research Network Education Committee and is Editor-In-Chief of Pharmacogenomics, Foundations, Competencies, and the Pharmacists Patient Care Process. So Dave, thank you so much for joining us today. Let's just jump right into question number 1 that we have for you, and we're sure our audience is very eager to learn. Could you share with us, Banaz and I have alluded to this in some of our previous podcasts, but could you share with us your perspective on PharmDs and the PGx education currently available in schools and the continuing education that they're currently able to obtain?
Sure. And first, thank you for the kind introduction. I've had an opportunity to work with so many great people over the last 33 years, and actually going back to almost 40 years. So I appreciate that. And boy, what a question you lead off with, because there's a lot to unpack there.
Yes.
With the 100 and say roughly 40 schools, let's say that number. I'm not sure where we stand exactly right now. But I'm going to give some history too, some background. In 2005, first survey came out looking at pharmacogenomics, or at the time pharmacogenomics education in schools of college and colleges of pharmacy. And at that time, there was certainly a lower percentage of schools that were offering pharmacogenomics, and this really was more so from a elective standpoint. A lot of this has to do with the fact that the expertise to teach the subject matter was
Sure.
not around as much as it is today, right?
Sure.
That survey was repeated in 2010, and we saw increased content really contact hours, not content. And there lies the problem, I think, is that
Sure.
from school to school, the content varies so greatly.
Yes.
And again, it's because we don't have ubiquitous expertise that can teach this subject matter across all the different schools that are out there. In 2020, I believe, part of that survey was repeated in a subset, and recognize that is post 2016. So 2005, 2010, 2020, I believe, was the last one. And 2016 was the year that the standards 2016 came out from the American Council of Pharmacy Education, where it was required to have pharmacogenomics in the curricula of schools and colleges of pharmacy for the first time. So having said that, that requirement fell into two places. One was in the basic, or I'd say applied science realm, where the genetic basis for drug interactions and disease states, and in a broader topic of genomics overall was covered. And then in clinical sciences, or clinical pharmacy, where it was connected to outcomes and therapeutics. And so those were the two areas. Now, having said that, we have seen different contact time across different schools. Some schools may have an introductory lecture, and that's it. It might be, this is pharmacogenomics, be familiar with the word, here's some terminology, that kind of thing. Other schools go to the deeper and broader connection with pharmacogenomics, maybe 10 hours or so, or maybe up to 30 hours. And some schools go over 30 hours of PGx, and those are few, of course.
Sure.
But the point is, and to your earlier podcast where you talked about education in pharmacogenomics, it's greatly varied, and there is no standard at this time. Now, I've always used pharmacokinetics as an example for a new implementation in pharmacy. I'm old enough to have been around when...
Wise enough, not old enough, wise enough.
Yeah, I guess that with age and being around for almost 40 years and doing PK and then PGx, that I think that we see some very similar occurrences with one big difference. So when the technology came out to allow us to look at drug concentrations in biologic fluids, that was the key to the clinical implementation of pharmacokinetics, where that information could be turned around more rapidly and have a clinical impact. And of course, we saw many different drugs that had narrow therapeutic ranges that had a PK need in the clinic, wherever that may be, ambulatory care, acute care, where have you. And so pharmacists were specialists at that time, and they started these therapeutic drug monitoring services. And that's why my fellowship was in therapeutic drug monitoring and pharmacokinetics. You won't see a lot of these services around now, because PK is more ubiquitous in the education of
Right.
pharmacy, right?
Exactly.
So, yeah, and so I think Becky and Vinaz that we're repeating this again, and it's almost painful because we didn't do it perfectly,
Right.
with pharmacokinetics, and then to see this happen again with pharmacogenomics is like, oh, come on, let's do better. Well,
Right.
yeah, right, yeah. So we've got that technology, and then these therapeutic drug monitoring services, and then as time went on, it became more and more a standard of, and I guess I would say competencies that were built
Sure.
almost organically into schools and colleges of pharmacy for PK. Now we've got, pharmacogenomics, and we've got the same issues, a lack of standardization of what is taught and to the depth of it.
Absolutely.
And so yeah, go ahead. I'm sorry.
I was going to say, and absolutely, we have a lack of standardization of, what does someone competent in pharmacogenomics look like? Of course, if we don't have a set curriculum, then we don't have a definition for, what does someone that's, an expert or very well trained in a particular, maybe even topic of pharmacogenomics. We can't define that without definitive education. That's what I'm trying.
Right. And again, we just don't have enough faculty across all the different schools to tackle that. And I think that one of the big differences now that is in place that was not back when pharmacokinetics came about were the board certifications.
Right.
Now, right? And so those are meant to have a standard competency, if you will. And I won't say a minimal competency, certainly not, right? So I think that's an issue that I think is needed to be tackled. At any rate, we think about the folks that go through pharmacy school now and what their education may be, and the ability for a pharmacist to apply this clinically, whether it's in the community setting or acute care setting or where have you, is really very, very different. I'm such a I don't know what the word is, nerd, pharmacogenomics nerd, maybe.
Yeah.
But I want to see where it's being practiced. So whenever I go to a new town, I go into a local pharmacy and I ask somebody about pharmacogenomics. I'd had conversations with my primary care doc, and I said, can we pursue this to have this in my record? And they said, sure. And so I go into these pharmacies and I say, listen, I've got this data on pharmacogenomics. Can you tell me what this may mean, just in general? And most often, unfortunately, I get the answer, I've heard of it, but I really don't know what it's all about. Right. I have had some very, very great responses as far as, listen, I don't know, but I'm going to find out and get back to you.
Right. Yeah.
Yeah. And I had one pharmacist pull their phone up right away and say, listen, here's a certain thing I found in pharmacogenomics. Maybe this can help you. So I really love that it's happening, but it's just not happening with the intent of the penetration of implementation that we'd like. And if you go back to implementation science, there really were ways to do this.
Oh, yes. Oh, yeah.
You know what? We should call this a PGx Dave movement, where anyone that knows about PGx and is a PharmD, or doesn't have to be PharmD, goes into a different town, visits a pharmacy, and has this question. And they took a survey at the end of the month. Cool? I like that. It's the PGx Dave movement.
Yeah, very grassroots, right?
Yeah.
So you've got this issue, which really is potentially going to be a bigger issue, at least from the community setting, where patients who have direct consumer test results can literally walk into the pharmacy with these results, at least right now from one company, and ask the pharmacist questions about CYP2C19, SLC01B1, and DPYD.
Yes.
And that's without any clinician in that pathway, right? They order the testing kit, they put saliva into a tube, send it back, get some results. So yeah, so we need to standardize not only the formal pharmacy education, but also then what do our pharmacists have available to them as far as continuing education? And, of course, we're all familiar with those 1 hour quick CEs.
Yeah.
You gotta love those though, Dave.
Oh, I'm glad they're out there. I absolutely am.
True.
But there's just so much more, and I think a lot of the approaches are to introduce the topic, and they just don't have the time to go to the breadth and depth.
Right. Yeah.
But having said that, we also have these, certificate training programs, and there are a number of those out there. And like the formal education in schools and colleges of pharmacy, there is no standard for what is taught in these certificate training programs.
That's correct.
So that same problem exists. Now, I've been lucky enough to work with a number of great folks who I'm sure you all know, and we rehashed the 2002 Competencies in Pharmacogenetics that was from AACP, and I think Julie Johnson was involved with that early on. That was, 21 years ago now. Yes. And in 2017, we updated those. And then pharmacy went to something called these entrustable professional activities, these EPA.
Right.
And so in the last year and a half now, we've redone the competencies again. So they're up to date. And I think that document, which is in the American Journal of Pharmacy Education, and it's freely available. And then also a document from the American Society of Health Systems Pharmacy, or pharmacists. I can never remember that. Boy, I've only known of the organization for 40 some years, and I can't remember.
There's a lot of acronyms out there.
Aren't there? The old alphabet soup.
Yeah, it's an alphabet soup.
But they also have a document, the roles for pharmacists in pharmacogenomics, clinical pharmacogenomics, I think it is. And they break it down very nicely from the standard for all pharmacists, and then what the specialist would do. So this is kind of where I see the landscape. There is no standard. I know at my institution, we've pursued a dual degree for our pharmacy students that want to do the PharmD and the Master's of Pharmacogenomics. We look at the PGY2 residencies that are out there, and I think those are the best, year-long patient-intensive learning are great. But there's really there might be 9 or 10 of those nationwide, right? And so, boy, how are we going to get everybody through that kind of education? So I think,
And something else that I've noticed just looking through, for example, pharmacogenomics job postings for companies looking for someone who specializes in pharmacogenomics, is they want the unicorn. They want that person that has that PGY2. And just like you stated, there's not that many opportunities for PGY2 out there, much less people that have completed those. So I often wonder to myself, how long do they go before they find someone that, has the qualifications that they think are necessary for that position?
Yeah, boy, that's a great thought, because, when they don't find these folks, then they get trained within the organizations themselves to the best they can. Now, I find it really interesting. You were, I believe, overboard when you introduced me, but I do appreciate that. But where I'm going with that comment is that I've never been formally trained in pharmacogenomics.
Right. The only training I have is a certificate program, but I have a heck of a lot of work experience.
Yeah, and that's another thing, right? I can't, and you won't find that on my CV, right? I mean, I've done a number of the certificate training programs, and those are very valuable. But again, we as a profession have not standardized those.
Right.
And so I can recall one occurrence in particular. I was in my office at Manchester, and I got a call from a resident in Columbus, Ohio, who was working in community pharmacy, and they were starting to implement pharmacy in their community setting. And I asked, well, what kind of education did you get in pharmacogenomics? Said, well, the company provided us with 4 15-minute modules to introduce each topic. And they were calling because they didn't feel it was adequate. Right? That company has since gone by the wayside. But I just thought, boy, there's a real extreme of
Yeah.
of one, right? And others do wonderful. And these certificate training programs come from really, really reputable sources. So they're doing their best. But I think we'll see some standardization coming. It's going to happen.
Good.
Yeah, and to that point, Dave, I think we've talked a lot with Becky and I have talked about this, and I think you and I have discussed this, where, to your point, just getting a CE is really not enough. The overnight CEs or the few hour CEs, you really have to have that experience. Now, where do you get it and how is a whole different story. But, understanding when you get a PGx report, and I always use this example, when you see that it says a poor metabolizer, it doesn't automatically necessarily mean there's a dose reduction, right? There's a lot of other things that impact, if and when you should be doing a dose reduction for that type of medication. So those are all those things that may not be on a report that you really have to know and understand to be able to truly have an impact on the guidance you're going to give either to the patient or the provider. So going back to what you were saying, besides the standardization, but we're not there yet. What do you think the pharmacist should be doing, or where is the lack of that? Where is that lack do you see? Is it just that experience? So, because we see a lot of pharmacists on social media, they're all, for lack of a better term, PGx experts, but it's just basically purely based on that CE that they've taken. Now, I'm not saying CEs are bad, but exactly what you said, it does give them an introduction to PGx, which is really definitely needed. But what do we do beyond that if you want to truly, get there?
Yeah, I think that the folks that are on social media are playing a really important part from a number of aspects. First, they're doing what is available to them, right, by and large. And that's great. Others have not taken that. And not only are they doing those things, but they're also promoting those. And that's good in and of itself. But I think overall for the profession, I think that there's got to be these kind of standards and competency statements that drive the overall education. So I'm not necessarily against those, right? I'm just saying that those are what are available. And they're, like I said, reputable sources, right?
Definitely.
AACP has one, Mayo Clinic. There's a number of different places that have these, and they're great. Now, I want to talk about your example about CYP2D6. Thank goodness the colleges and schools of pharmacy are doing such a wonderful job at making sure these students and these student pharmacists are watching the patient, right? Looking at the patient and seeing what's going on with the patient. That's certainly primary, regardless of what their genetics may say, right? But to your point with the CYP2D6 as an example, I've said for a long, long time that we as pharmacists may be doing the best we can do with evaluating a patient's medication list. However, it may not be optimal. In other words, we're looking at the patient, how they're doing, say, blood pressure wise or other indices, depending on what the diagnoses are and what medications they're on relative to those diagnoses. But are we able to interpret the information appropriately? So CYP2D6 poor metabolizer, first of all, if they're on active medications that are provided to them as opposed to, say, prodrugs, right? There's that context. Right. If they're on active medications provided to them and they are responding a certain way, we certainly want to make note of that. That's the most important part. But it's the interpretation. You can go into any pharmacy system and find a drug-drug interaction checker. And you may see the situation where a patient receives a medication, then receives another medication that may be an inhibitor of CYP2D6, and it's alerted via some alerting system. And of course, if the person is already a poor metabolizer, there may be nowhere for them to go as far as downwards in drug metabolism. And if they're responding to the medication the way that they're supposed to, certainly we're going to be monitoring the patient, and you evaluate that interaction in a different sense than if the person were an intermediate metabolizer and they're receiving an inhibitor and phenoconversion can occur. So I think that there's so many layers to evaluating a PGx test results report. from the dosage formulation standpoint, to the disease standpoint, to the physiology standpoint, to the underlying genetics. All of that has to be taken into account. I think it kind of builds, right? You've got the underlying genetics, and then you've got the patient's physiology. So imagine somebody who's in their later years, say 70s or 80 years of age, and so they've got a different physiology as far as drug eliminating organs. And then the pathophysiology that you layer on top of that, well, it may also impact those organs. And all of that has to be understood with the underlying genetics there. I can remember very vividly, one of my first positions was being a transplant pharmacist way back in the very late 1980s and early 1990s. And of course, PGx wasn't there at the time. And I happened to be at the University of Pittsburgh where FK506 was being developed. And we know that now as tacrolimus. But I can remember patients who were being admitted, and I say transplant pharmacist, that term was used loosely from my perspective, for me, because I wasn't really post-transplant, I was pre-transplant. And it didn't matter what your genetics were, what the patient's genetics were. They were all poor metabolizers because they had just no functional liver. And so I can remember giving very low doses of medications and seeing patients just have reactions that were really unexpected. So my point is that we have to review the patient's medication list in the context of their physiology, pathophysiology, concomitant medications, and of course the underlying genetics. All that has to be put together, and I don't think we're there yet. So.
Yeah, no, definitely. And that's the one I always talk about. The report doesn't capture all the things you just said. It's just very, very basic. Well, maybe basic is not the right term, but I want to say raw data, because it doesn't capture, like you said, the phenoconversion. Maybe some reports have it, maybe don't. The health history of the patient, or if they've gone through chemotherapy. Are they missing a kidney? There's a lot of things that report doesn't capture that we need to take into an account. And then if there's a genetic variation for that specific individual that they're on that medication, that doesn't necessarily mean there needs to be a change in therapy. You have to use that, the report as another tool to guide with the presentation of the patient. So there's all these factors that I don't think is really fully understood. So when we look at a report, we just take it at face value. And I speak generally, I'm not speaking of every single person, but that those types of education, I feel, come with experience and actually sitting down with the patient, having to read it, understand it, going back to your pharmacokinetics dynamics and everything else to have a good full report for a patient, to be able to give it to either patient or a provider. So those are really come with the experience, right?
Right. Yeah.
They can't be all taught in every discipline. You got to talk cardiology, oncology. There's a lot. It's just a lot.
Yeah, I think the empiric knowledge that individual pharmacist gains following some education in pharmacogenomics is likely the most valuable, right? When they're seeing patients and as they see more and more patients, they build this experience that nobody else can really get as far as direct patient care, unless you're an individual who's done a PGY1, then you go to the PGY2 and focus on pharmacogenomics. But I think that all these efforts out there are good things. I guess that one of the comments that Howard McLeod made, which I absolutely love, was that we'll really know that pharmacogenomics is there when we don't talk about it anymore, right? Because it's just going to be a given. And I really love that.
Interesting.
Yeah, I love that saying, right? I think, of course, Dr. McLeod has just been an absolute leader in giant in pharmacogenomics for a long time. So I've always appreciated his insight. But anyhow, I think that the interpretation is so intricate compared to the way that it may first be perceived. As a patient had a blood transfusion recently before testing, is the patient have a rare variant that's not tested for? And so, you get a result back to say it's a, star 1 as an example, a deferred start 1. And so there's just so much there, and we're all learning more and more. But yeah, I'm glad the effort's there. It's great that it's on social media. It's great that people are talking about it, and there's a lot of opportunities for people to learn. It's just that right now those opportunities aren't standardized. So I guess I've talked about that enough. So.
No, you can never talk enough about that. But in your ideal world, what should pharmacists that want to really dive deep into get into this? Like you walk into one of these pharmacies and one of them's like, oh my gosh, that's amazing. I want to learn. And that's what I want to implement in this pharmacy. Glad you walked in here, Dave, today. So what would be those steps that you would have them do in a more idealistic world if you could make that happen? Yeah,
so I think a progression, right? I think their first introduction may be a 1 or 2 hour CE. I know that we were involved with putting together a CE recently. It's freely available that looked at pharmacogenomics for drugs that were in the top 200 by number of prescriptions. And so I think that background, initial CE, some context to drugs that they see commonly would be appropriate. Look at the literature, look at some of the training programs that are out there. But I think underlying all of that is to have a checklist next to the pharmacist, and that would be the competency statements. Have the pharmacist look at these competencies for clinical pharmacogenomics and look at the description of the competency statement, and then fill in the backstory of each of those competency statements. I think you do that on your own, you're going to put yourself in a really good position. I mean, these competency statements talk about many different aspects, from the ethical, legal, and social implications kind of intertwined throughout or interwoven throughout, talking about when to refer a patient for a genetic issue beyond pharmacogenomics, talking about understanding disease risk versus carrier status. I think there's just so many pieces of information that can be driven by those competency statements.
Yeah.
And, an individual can do this on their own. It takes effort, right? It takes a lot of work to do that and to learn it on your own. But I think that's an underlying approach, and fill that in with a certificate training program. But you need to go beyond that, and then also watch for what standardization may be coming in pharmacy.
Yeah,
I think we're all trying to figure that out, really.
Yeah, it's a work in progress, but it's your genetics. It's always going to be complex. Always new things coming, more things to learn, but it's a good start for sure. So here's one other thing. There's been a lot of pharmacists, again, doing the right thing, trying to, learn from starting the CE, right? That's a way to go. But assigning an acronym to their name with the CPGX and not realizing that when we do that, we're really discrediting ourselves, since it's not an accreditation, right? So can you tell us about that or your thoughts on that? Because Becky and I have had an episode speaking about that, to educate pharmacists. Maybe that's a lack of education. They may not even know. So wanted to get your thoughts on that.
Yeah, so I think that, the standard has been typically to have formal education abbreviations after a person's name based in the profession, right? Like BS for Bachelor of Science, or PharmD for, even from the standpoint of the early 2000s when we switched to the all PharmD, there were individuals who did post Bachelor of Science PharmDs, right? So a BS PharmD means something different than the PharmD to them, right?
Sure.
And then we think about board certifications, right? A board certified geriatric pharmacist, as an example. Those are standards. And I think that those abbreviations come when they're standards. And as we've talked about, the certificate training programs are not standardized, so they mean really something different. And then, of course, if an individual has some recognition from an organization, You might see, FCCP, so Fellow of the American College of Clinical Pharmacy, as an example, or APHA, right, Fellow of the American Pharmacists Association, whatever. Those are, but there's a standard to get those titles also, right? And so the difference is standard versus no standard. And so typically we haven't been putting letters after our names professionally when there's not a standard there.
Right.
I think it's important for people to say, okay, what is CPGX? Okay, and maybe that drives somebody to look into a certificate program.
Sure.
And so I think that's okay too. I think it's all evolving. I think it's all, we're in this evolution, right?
Yeah. Well, I remember 9 going on 10 years ago when I first started out in pharmacogenomics, and I was teaching the Test to Learn program, and students would ask me, so what do we call ourselves now? Or, what can I put behind my name? They wanted to distinguish themselves. They wanted to let people know that they had this newfound pharmacogenomics knowledge. And, the answer wasn't clear 10 years ago. The answer isn't clear today because still, there's not a defined curriculum and there's not a defined acronym to go with it. So, yeah, this is not a new issue.
Yeah, so I agree. And I think it's just an evolution. I'm
Sure.
glad we're evolving. I would be concerned if we weren't. But
Exactly.
I'm sorry.
I said, absolutely, yes.
Yeah. So another example would be with master's degrees, right? We see somebody with MS after their name. And I've often wondered, MS in what, right?
Yeah.
I mean, there I do think that it should be MS, maybe PS for pharmaceutical sciences, or MS PGx, right, for masters in pharmacogenomics. But again, master's programs are accredited by a higher learning commission, typically some sort of accrediting body. So again, that standard I think is still there, and we'll get to it. But again, I will say that I started in pharmacogenomics in the late 1990s when I spent some time looking at N-acetyltransferase, and back then there was a antiarrhythmic drug that we used to use, procainamide, right, and acetylprocainamide, and there was a bunch of stuff going on there, and anyhow, so I kind of started that in the late 1990s, and I've never had any formal training, but I think that's where that empirical learning is so valuable, because we can't all do the PGY2s.
That's right. And I mean, and like you've talked about your research experience, you've been a professor, like, for example, my pharmacogenomics knowledge is heavily vested on market access, payer reimbursement, medical necessity, that side of pharmacogenomics. So there's no certificate program for that I'm aware of. Like, we all can contribute, I guess is what I'm getting at, is that, what would the end all be all pharmacogenomics education look like? Of course, I guess when we go to pharmacy school, we don't learn a lot about payers and payer policies and such either. I think that we have to learn that on the job typically as we go, but
yeah, typically when you call the insurer and they say, no, we won't pay for it, right?
Yeah. So yes, there's different types of pharmacogenomics education that we can all contribute, or knowledge we've gained through work experiences, I guess, too. So, well, on that note, how about giving us an update on your research with pharmacogenomics and opioid use disorder?
Oh yeah, I thanks for asking about that. I was really fortunate to be asked to help out with a project, and kind of taking a little bit of it to heart, just from the PGx standpoint. So I'll tell you, Dr. John Sprague in the state of Ohio is leading our opioid issue. Of course, we've got an unfortunate ranking near the top of overdoses and deaths in Ohio, and that's that's where this is driven by. And Dr. Sprague has just been fantastic at bringing folks together to get different aspects completed for the state of Ohio, and hopefully it'll go beyond Ohio. But I was involved in really an analysis of a study looking at opioid use disorder risk based on pharmacogenomics, and recently had a group of us had published a paper on that in Clinical Pharmacology and Therapeutics, and it's driven some other aspects to look at the biogeographical genetic ancestry groups and what risk might be in different groups based on genetics. And I think that if we can get to a concise and robust genetic risk analysis, that's the real goal. And so we identified 6 variants, 4 of which were related to increased risk of opioid use disorder, and 2 that were related to decreased risk of opioid use disorder. But there's much more backstory to that. Dr. Sprague and Dr. Firmuth from Cincinnati, they've just been great. It's just a great group of individuals. I can't name everybody, and I'm just one of the folks in really helping out in that aspect. But I think we all recognize the opioid crisis that we have, and we're all putting an effort to try to at least soften that to some extent, if not a great extent.
Oh, sure.
Yeah,
Absolutely.
we appreciate you doing that, and we can't wait to hear the results, or as you guys and the team continue working on that, and we appreciate you doing that. It's really much needed for sure. But we're at time. We can't thank you enough for coming on, Dave. I know you're busy and doing so many things. I hope you consider to come back and continue conversations, and maybe next time it will be about the research you have, and you might have some results with it. We will all want to hear about it.
Yeah, so there'll be a change coming for me. Are we
the first to hear it?
No, I don't think so. I started my.
I felt special for a second, Dave.
Sorry. I started my pharmacy path in 1979, and as of May 22nd, my formal career will be ending. I will be retired.
Oh, yeah, that's good though. I mean, good and bad, but good.
Well, hopefully you'll continue to be a mentor and educate, because we definitely all need it.
Oh yeah,
sure.
Certainly I'll be doing some consulting work, but most of my time is going to be spent with my grandsons. So I'm looking forward to that. But thank you so much.
That's awesome. Well, that's awesome. Well, thank you so much for coming on, Dave. And thank you, everybody, for tuning in. We do a lot of PGXing on here, the PGX science, clinical application, and business. And we hope you learned something today or two. We love to hear from you. So what can we teach you? Drop us a message on LinkedIn and let us know. And please make sure to share the link to this podcast with everyone so they too can tune in and listen to the PGx for Pharmacists podcast. Make sure you leave us a review on Apple Podcasts or Spotify, and you can visit us on PGx4rx.com to listen to all our episodes.
Thanks for your interest in PGX and for spending some time with us. Please share this podcast and leave us a review on Apple Podcasts or Spotify. For all of our episodes, please visit PGx4rx.com. That's PGx4rx.com.